As a physician, I think it's a privilege to learn as much as we can for our patients. I was at a dinner meeting last night with Chuck Pagano, who's the Indianapolis Colts former head coach, and he's a warrior that's been successful in the sports world, but as a hematologist oncologist, he kind of let us know during these meeting last night how important, how much trust that our patients rely on us, whether you are very successful as a football coach or whether you're being treated by a local community oncologist. It's very important that we learn as much as we can to provide the best care because our patients trust us. Now, going along your question, I think for me, there's been a lot of breakthroughs in terms of treatments. I want to kind of focus on treatments that would affect the community oncologist, because there's so many different key trials that play a big role. However, I want to see what studies will start making changes tomorrow for our new oncologists. So these are studies that I feel will make a difference for tomorrow's clinic. And so one study in particular is for chronic lymphocytic leukemia. And just to kind of let the audience remember about chronic lymphocytic leukemia is the most common leukemia in America. And it's been shown that in the past, the treatment has been for chemotherapy. And then we actually had a targeted medication called rituximab. And so before this meeting, the standard of care was called chemoimmunotherapy, where you would actually treat with rituximab and chemo, most commonly bendamustine or fludarabine and cytarabine, fludarabine, Cytoxan, and rituximab. Now, with the plenary session yesterday, they did a phase 3 clinical trial where they compared 3 arms. One group of patients, it was a randomized phase 3 clinical trial, national, multi-center study. One group of patients received ibrutinib, which is a Bruton tyrosine kinase inhibitor. The second group received ibrutinib with Rituxan, and the third group actually received bendamustine Rituxan, which is considered a good comparison arm. What they found is ibrutinib, which is a pill only, showed superior progression-free survival, even compared to the rituximab with ibrutinib, and also superior to bendamustine Rituxan. So the take-home message is, based upon this new study, ibrutinib should be the new standard of care for patients that are older patients. In the study, they've studied patients greater than 65 years old. One caveat is the patients in the ibrutinib arm actually have more atrial fibrillation, so it's going to require us as hematologists to be more aware of the cardiac side effects and the arrhythmias, and actually checking out any kind of tachycardia or any kind of arrhythmias. So that's one study. The second study I think is very important is in the myeloma world. Myeloma has gone through a lot of transformation. I met one of my friends, Dr. Klein from NIH last night, and we were kind of talking about comparing myeloma to diffuse large B-cell lymphoma. And we did a little historical context of looking in the past, and it was interesting. Right now, the standard of care for diffuse large B-cell lymphoma is R-CHOP. And it started out as CVP, and then we showed that CHOP was superior to CVP. And then afterwards, we showed that R-CHOP, when the Rituxan was actually FDA approved, was superior to CHOP. So similarly in the myeloma world, the standard of care since the plenary session a couple years ago was VRD, which is Velcade, Revlimid, and Dex. And that's been shown to be superior. Now with this new CD38 daratumumab, that's been shown in ASH to be a candidate to be in the first-line setting. So daratumumab is a CD38 monoclonal antibody, and it's been shown superior results in some of the studies in the phase 1, phase 2 studies. And tomorrow we have a study that's going to be eagerly anticipated by all of the hematologists called the MAIA study. In the MAIA study, it's a phase 3 clinical trial, randomized, where the treatment arms are Revlimid and Dex versus daratumumab, Revlimid, and Dex for patients that are transplant ineligible. And this study is going to show superior PFS and superior OS. So that right there should be considered a standard of care for patients that are transplant ineligible for multiple myeloma. Now going forward, the other thing that I've noticed is for our patients with transplant eligible, there was some early updates on something called the Griffin trial, which is a phase 2 clinical trial, and it showed that patients that receive VRD, Velcade, Revlimid, and Dex, and the comparison arm was daratumumab, Velcade, and Revlimid and Dex, and it showed that it did not increase toxicity and actually increased response rate. So I'm excited about that study once that matures. The third study that I found very interesting is it was also a plenary study session yesterday where our patients with myelodysplastic syndrome. Myelodysplastic syndrome is a very tough disease because underneath the microscope in the bone marrow, it's a myeloproliferative kind of a process. However, our patients end up with low red blood cells and they require constant blood cell transfusions. And so in this study, they found this new medication, luspatercept, that you actually give the patients and actually showed that the patients receive less blood transfusions. Because receiving too many blood transfusions can actually increase toxicity and iron overload disease. So I thought that was very exciting. There's actually some preliminary phase 2 studies for our thalassemia patients, so that's another study I'm kind of keeping an eye on. One more study that I think is kind of interesting, and that's in the lymphoma world. Just kind of mentioned earlier, our standard of care for diffuse large B-cell lymphoma was R-CHOP, and it's currently R-CHOP for germinal-centered question activated B-cell subtype. There might be a new standard of care in the future. However, in this study for the young, fit, 18 to 60-year-old patients, stage 1, stage 2 diffuse large B-cell lymphoma, they actually showed some preliminary studies that showed maybe 4 cycles of R-CHOP might be equivalent to 6 cycles of R-CHOP, which much less toxicity. So I'm looking forward to that study and seeing if that would be considered the new standard of care, 4 cycles of R-CHOP versus 6 cycles. The patients that got 4 cycles of R-CHOP still received 2 more cycles of Rituxan. So, but hopefully it's been an action-packed, a lot of great studies in this meeting.